Okay, good afternoon. So today we are going to start with another system, and that is the cardiovascular system. In the cardiovascular system, we are going to deal with blood, with the heart, and with the blood vessels. So today we are going to start with the blood, and we will continue with the heart and the blood vessels during next week. These are the functions of the blood. It's obviously it's a transportation of oxygen, carbon dioxide, metabolic wastes, nutrients, hormones which circulate in the blood, so transportation of these substances, and the regulation of the body temperature. Probably this was mentioned as early as the integumentary system when we dealt with some blood vessels which are located just underneath the skin in the subcutaneous tissue, and we mentioned that these blood vessels, they dilate and the circulation increases in them whenever there is when you do exercise or whenever there's a hot weather, so that to increase the dissipation of heat, and the reverse takes place in cold weather. So that's the second function that the blood does. And then we have the protection from diseases and infection because of the presence of cells that also belong to the immune system, and these include the white blood cells. So these are the main functions of the blood. The physical characteristics of blood is that it is a little bit thicker, which is more viscous than water, obviously because there are cells or there are formed elements in the blood. So that's why the blood flows slower than water, like pure water, because of the presence of formed elements. And it's thicker and a little bit stickier, more adhesive. Okay, and it's slightly higher than body temperature, 38 degrees as opposed to 37.5, and slightly alkaline, and 8% of the body weight. And the volume of the blood that we have in the body varies between male and female, and the reason for that is the difference in average body size. So 4 to 5 liters of blood circulating in the body of an average female, and 5 to 6 liters of blood circulating in the body of an average male. Blood is essentially a connective tissue, and probably we mentioned that from the beginning, that there are different types of connective tissue. There's the general connective tissue, there is the hard connective tissue like cartilage and bone, and there is the fluid connective tissue. So it's a kind of fluid connective tissue, and being a connective tissue, then it has, like the other components of connective tissue, it has cells. I would put them between like quotation mark, let's say formed elements or cells, and fluids, okay, which is the extracellular matrix, like which is any extracellular matrix that is present in the connective tissue. So this fluid constitutes plasma or forms the plasma. We're going to talk about the components of the plasma. It's 55% of plasma, as you can see it here, and then 45% are the cells or the formed elements. So you can see here in this test tube, when the blood is put in a test tube and then it is centrifuged, rotated very rapidly in a centrifuge in a machine, then the formed elements, which are heavier than the fluid, they will deposit below, and you can see that most of these formed elements, most of these cells, in fact, are red blood cells. So the red blood cells, they actually 99% of the cells are red blood cells. That's why only for 1% here we have what we call the buffy coat, which is the yellowish coat, very thin area, and this is composed of the remaining solid elements of the blood, which are the white blood cells and the platelets. And then we have at the top, the lightest part is the fluid, and this is the plasma, 55%. Okay? So returning back to the plasma, the blood plasma is mainly, which constitutes, the plasma constitutes 55% of the blood. Now, the plasma itself is made 91% of water, and then the remaining parts, it consists of plasma proteins and some other substances. So it's mainly water. That's why it is, we said that it's a liquid connective tissue, 91% water. And then we have plasma proteins. These plasma proteins are mainly, they are produced in the liver and they are present in the bloodstream. Mainly we have three types of plasma proteins, the albumin, and these albumins, they are important for the osmolarity of the blood, osmotic pressure of the blood. Like they make the blood having high osmotic pressure, and that's why when blood reaches the extracellular tissues near the capillaries, then the fluid that is present in the extracellular compartment will move back to the blood in order, because the osmolarity of the blood is higher than the osmolarity of the extracellular tissue. Probably you will study that in the physiology, or maybe you have studied it by now. And that's why when in certain diseases, especially in kidney disease, when there is loss of proteins, excessive loss of proteins because of the destruction of the glomeruli of the kidney, then the osmolarity of the blood will be reduced, and you find that the patient's the face of the patient or even the other parts of the body become puffy because their extracellular fluid is retained. It is not returned back to the blood because the blood has low osmolarity. So albumin maintains the osmotic pressure of the blood. And then we have the globulins, and these are globulins. They are produced by the plasma cells. We're going to talk about plasma cells in a moment. They are B lymphocytes that produce antibodies. These are called immunoglobulins to fight against infection, to produce what we call antigen-antibody complexes. And then the fibrinogen, the third type, fibrinogen, which converts into fibrin. And these fibrin, as the name indicates, they will form like fibrils, network of fibers that are important for clotting, blood clotting, together with because the spaces between these fibrils will be clogged and blocked by the platelets, another component of the blood. So all in all, three types of plasma proteins. The albumin, each one has a certain function: the albumin, the globulin, and the fibrinogen. And then the remaining 2%, we have electrolytes, we have nutrients, the hormones that we mentioned that they circulate in the blood, vitamins, gases, CO2. By the way, most of the CO2 is dissolved in blood. So we mentioned that the blood will carry oxygen from the lung to the tissues, but oxygen is carried in red blood cells, in the hemoglobin of the red blood cells. And this hemoglobin only carries like 1/4 of the carbon dioxide, but all the oxygen. But most of the carbon dioxide is not carried in the, the CO2 is not, which is carried from the tissues back to the lung, is not carried in the red blood cells. It is dissolved in the plasma. Does not need the cells. Does not need the RBCs. Also, the waste products like urea and ammonia are dissolved in the blood plasma. So you can see here that blood plasma is 55%, the formed elements are 45%, the plasma is 7% protein, mainly water and other solutes. The proteins are mainly three types of proteins. Then we come back to the formed elements, and you can see that these are three types of formed elements. Red blood cells, also called erythrocytes, and actually sometimes they call them red blood corpuscles, because as you will see in a moment, they are not actual cells. They were cells during their development, and then they lose their nucleus. So they are no more cells. They are more like corpuscles. That's why it's better to use the formed elements, because not all the components are cells. The white blood cells, the leukocytes, leuko means white, so the leukocytes, they are actual cells. They have nuclei, as you will see, and you can differentiate between them according to the shape of the nuclei, according to the granules that are present in the cytoplasm, because they can be either granular, where you can see granules in the cytoplasm, or agranular, where you can differentiate between them according to the shape of the nucleus. The platelets are definitely not cells. They are fragments of cells. There's a very big cell located in the bone marrow, which is called mega, indicating the type of the cell. So it's not a macro, it's mega karyocyte. It's so big, and fragments of the cytoplasm of that cell, which is present in the bone marrow, I'm going to show them to you in a moment. They go to the blood and they form these disc-shaped structures, which are platelets. So definitely they are not cells. You can see here that these are the numbers in 1 ml of platelets, white blood cells, and the red blood cells. For the white blood cells, it's not only the number that matters, but the type of blood cell, the type of white blood cells, the percentage of the type of white blood cells that also matter. And this is what we call a differential count. So when you ask for CBP, complete blood picture, you will get a report telling you about the amount of red blood cells, the amount of white blood cells, but this is not enough. They will give you the differential. Like 70% are polymorphs, 20% are lymphocytes, 2% are monocytes, 1% are eosinophils, and less than that are basophils. So this is the normal. For example, if you find like any one of these percentages is increased, it will give you an indication of the disease. Like for example, if it is the problem is with let's say a parasitic infection, then you will have more of the eosinophils increased. If it is an allergic reaction, then you'll have more basophils, and so on. So if it is a viral infection, you will have more of the lymphocytes, and so on. So it's not only the number that is important, but the percentage is also important, the percentage of white blood cells. Now let's start with the first one, the erythrocytes, the red blood cells or red blood corpuscles. The normal count is 4.8 in females, 4.8 million per cubic millimeter. And in the male, it's a little bit higher in the male. And of course, this is per cubic millimeter, so it is not related to the size, to the average size. The reason here, the difference, because females, especially in the reproductive time of their life, they have menstruation. So they are continuously and constantly losing blood. So that's why the average number of RBCs is less in a millimeter, is less than that in the male. And this will be also reflected on the percentage of blood volume occupied by RBCs. We mentioned here that the percentage is 45%, but we didn't mention the sex. So it is more in the male, in fact. In the male, it's 47%. In the female, it's 42%. The percentage of the volume of RBC in the blood. This is what we call the hematocrit. So the hematocrit also it will be given in a report of a complete blood picture. So you can know it reflects the amount or the volume of RBCs that you have in the blood, because the reduction in the number of RBCs or the reduction in the amount of hemoglobin that they contain, this will reduce the oxygen binding capacity of the blood and results in a condition which is called anemia, which is either because of reduced RBCs or reduced hemoglobin, amount of hemoglobin, main reason of anemia. This is the shape of red blood cell or erythrocyte. It's biconcave disc, as you can see. It is about 8 micrometer in diameter, and this diameter is definitely larger than many of the tiny capillaries in the body. And because the RBCs have to reach all these capillaries, then you will expect that these RBCs, they will try to fold themselves in order to navigate through these capillaries. Being biconcave in shape, this will help them easily fold. And there's another feature here that they have a good glycocalyx. And if you remember, we mentioned that earlier. The glycocalyx means glucose attached to the cell membrane, and this will absorb more water and make the cell slippery. So they are more slippery, and that's why they can navigate. This was mentioned in block 1, and they can navigate through the tiny capillaries. Being biconcave means that they are flexible in shape when they pass in narrow passages, and also it increases the surface area per volume. So they can exchange more gases because the surface area will be increased. How they become biconcave? Because they lose their nucleus while they become mature. As they become mature, they lose their nucleus. Not only their nucleus, they lose all the other organelles. So they start with losing the nucleus, and then they will lose all the other organelles. So that's why they can become biconcave. And because they lose their nucleus, because they are always changing their shape, then any problem, any injury, any defect in the cell membrane, or any defect in the cell in general, cannot be repaired, because they don't have the organelles, they don't have the machinery for protein synthesis, and they cannot repair themselves. So that's why they have a limited lifespan of 120 days, and after that, they are going to be destroyed. In addition to the fact that the glycolipids or the glycocalyx makes them slippery, they have certain glycolipids in their plasma membrane. These are the glycolipids, like this one here. Glucose, carbohydrate attached to the lipid molecules, so making glycolipids. So these glycolipids in the plasma membrane, they form the what we call the blood group antigens, either the ABO blood group or the RH rhesus, RH like positive or negative blood groups. They are the glycocalyx, depending on the glycocalyx that is present in the wall of the RBC. So this is the life cycle of the RBC. It is produced in the bone marrow. There are precursor cells which are present in the bone marrow, and they are, of course, they are nucleated, and then they will be released into the blood after they lose their nucleus. So the proerythroblast, as the name indicates, blast means forming cells. Blast, like for example, osteoblasts, if you remember, or chondroblasts, and so on. Fibroblasts. So we have proerythroblasts. They produce red blood cells. They lose their nucleus, become what we call reticulocytes. Reticulocytes are released into the circulation, into the blood circulation. And within 2 days, these reticulocytes stay in the blood, and then after that, they change into a mature RBC after they lose the remaining part of their organelles. So first of all, they lose their nucleus, they become reticulocytes, and then they retain some ribosomes and endoplasmic reticulum and mitochondria. They are going to lose that as well, and become red blood cells within 2 days. They circulate in the blood, and then once their lifespan is done, and they have a lot of defects in the cell membrane, they will become recognized by cells which are present in the liver and the spleen. Okay, these are residing cells, macrophages, special types of cells, macrophages. They are present in the liver and spleen, and they destroy these old, deformed RBCs. And as elsewhere in many other places, then the structures that were used in the production of RBCs, most of them, they will be recycled. So as you can see here, that the cell membrane, the proteins of the cell membrane, and the globin portion of the hemoglobin molecule, because the RBC mainly contains hemoglobin molecules. So the globin is a protein, and the cell membrane is mainly formed of proteins. These are going to be reused again for the production of new RBCs. And then the hemoglobin has a heme portion, and this heme portion partly is a pigment and partly is an iron ion. So again, these iron ions, which are present in one hemoglobin molecule, there we have 4 of them, they will be recycled back to the liver and reused again. And the heme portion of the hemoglobin, the pigment portion, is going to be changed into what we call biliverdin and bilirubin and excreted in the bile. So this is the reason. This is the part that's going to be get rid of the pigment part of the hemoglobin, and it's not only just excreted as waste, but as you will see later on when we study the digestive system, this bilirubin is very important. The bile pigment is very important for the absorption of fat from the small intestine. So it serves some other function before it's going to be excreted. Yes. Yeah, so like with jaundice, we have different types of jaundice. So one type of jaundice is that's called obstructive jaundice, and this is a problem in the biliary passages, when the biliary passages cannot excrete the bilirubin into the gastrointestinal tract. The other type of jaundice is called prehepatic jaundice, and this is usually accompanying blood diseases. Whenever there is excessive destruction of red blood cells, then there will be more bilirubin or biliverdin that cannot be dealt with by the liver because of this excessive destruction of RBC, and this will result in jaundice as well. Okay? Yeah. So worn out cells are removed by macrophages, and all the breakdown products are recycled, whether protein, whether the pigment, whether the iron, they are going to be recycled. This is the hemoglobin molecule. It consists of 4 polypeptide chains, 1, 2, 3, and 4 polypeptide chains of globin. As a protein, it means polypeptide, multiple amino acids chain. And then each one of these chains has a heme pigment attached to it, and each heme contains 1 iron ion, where 1 oxygen molecule is going to be attached. So in other words, each hemoglobin molecule can carry 4 oxygen molecules. This is the normal level of hemoglobin. We have 12 to 16 gram per 100 ml of blood in the female. In the male, it's more because males have more red blood cells than the females. Because they have more red blood cells, then they have more hemoglobin. Okay? Because the hemoglobin is part of the red blood cell. Now, each hemoglobin can carry, as I said, 4 oxygen molecules, and hemoglobin also transports CO2, as I said. Part of the CO2, 23%, about 1/4 is transported by the hemoglobin, but it is not transported by the heme portion. It is transported by the globin portion. So it's not going to compete with oxygen. The problem here is with carbon monoxide, which competes with the site of attachment of oxygen, not carbon dioxide, carbon monoxide. Most of the carbon dioxide is transported as dissolved in plasma, not in the red blood cell. And as is mentioned here, CO2 travels dissolved in blood plasma. And this is to tell you about anemia. It is a reduction of oxygen binding capacity of the blood because of reduction of the amount of RBCs, the reduction of amount of hemoglobin. So that's why oxygen does not reach the tissues as efficiently. The patient will become easily tired. There will be intolerance to cold weather. If there's reduced hemoglobin, then the skin will be pale, especially the mucous membranes. If you look at the conjunctiva, you will find it is pale, there is pallor. So these are the features of anemia. Now, this is how the production of red blood cells is controlled. You look at this side of the slide. So whenever there is a reduction in the amount of oxygen delivered to the tissues, and one of the tissues is the kidney. The kidney, by the way, is an endocrine gland. And if you go back to the probably first or second slide in the endocrine system, you will find that we mentioned that there are endocrine glands which are exclusive endocrine glands. They have no other function, like for example the thyroid gland. But there are many other organs in the body that have endocrine function as well as their other functions. As an example, let's say that we mentioned the hypothalamus as one of the examples. The pancreas is an exocrine endocrine gland, and the kidney. There are cells in the kidney that secrete a hormone which is called hemopoietin, and this hemopoietin, it increases or it encourages the process of production of red blood cells. So whenever there is a reduction in the oxygen carrying capacity of the blood, then the kidney is going to produce the hemopoietin, and this will increase the amount of number of red blood cells, circulating red blood cells, and this will have a negative feedback mechanism. Now, returning back to blood doping can be in different ways, either by injecting blood, like having more and more blood transfusions. So this increases the amount of red blood cells, and because the excess fluid that you have it from the blood transfusion, you are going to lose it, is going to be lost. But what remains is the amount of RBCs. So there is increase in the amount of RBCs in the blood if you continue injecting blood. And this will make the oxygen carrying capacity higher. And that is how it was. Now it is banned, it is illegal, but some of the athletes were using it before to increase their oxygen carrying capacity, or they can inject a synthetic product which mimic the erythropoietin. So they will produce more and more RBCs. But there is another method here, which is quite intelligent. It's natural blood doping. And that is that's how they do it. The athletes, they train in high altitudes, in areas that are like on a top of a mountain. And on the top of the mountain, usually if you live on the top of the mountain, gradually you have increase in the amount of red blood cells, because the amount of oxygen in the air, in the atmospheric air, is less than at sea level. So you will have naturally, because of this feedback mechanism of erythropoietin, that you are going to have more red blood cells in your blood to increase the oxygen carrying capacity. So those athletes will go on the top of the mountain, they will train there, they will have more naturally formed red blood cells, and then they will compete at sea level. Okay, so they have more stamina, let's say. But the problem here is that the increased amount of red blood cells, increased number of red blood cells, increases the viscosity of the blood. So the blood becomes easily clotting, and it forces the heart to work harder and harder. That's why it is so dangerous to do this. Here's an optional video of a story of an athlete who was using these, injecting medication to increase the amount of red blood cells in his blood. Now, white blood cells, leukocytes. Leuko means white, and cytes means cell. So those have a nucleus. Those are true cells, not like the RBCs, not like the fragments, the platelets. They have a nucleus, but they don't have hemoglobin. They don't carry oxygen. And they have a membrane protein, which gives them what we call major histocompatibility antigen. So they are unique cell markers. And they can be classified as granular or agranular, depending on the presence or absence of granules in their cytoplasm, as seen by light microscopy. What we do when we study, or what we call read a blood film. This is a blood film. You can see that most of the cells here are red blood cells. Isn't that right? So look at these red blood cells. You see that the center of red blood cell is faint. It's not that dark red. Why is that? Because they are biconcave, okay? So they are thick at the periphery. They are very thin in the center. And you can see that most of the cells, we mentioned 99% of the cells are red blood cells, and this can be clearly seen in the blood film. So granulocytes and agranulocytes, and then each one of them is divided into subtypes. So we have neutrophils and eosinophils. They like acidic dyes, like eosin is red in color, and basophils, they like the basic dyes, and they will usually, the granules will become purple in color. The agranulocytes, we have either monocytes or lymphocytes. Let's start with the most abundant type of white blood cell. Like almost 70% of the white blood cells are neutrophils. They have granules in their cytoplasm, but these granules, they are faintly staining. They don't have affinity neither to the basic dyes nor to the acidic dyes, so they are neutral loving. They are neutrophils. The other name of these neutrophils is that they are called polymorphonuclear leukocytes. polymorphonuclear because, as you can see, that their nucleus consists of about 2 to 5 lobes, and they are connected by narrow bands. So the nucleus is multiple poly shapes, polymorphonuclear leukocytes, either 2, either 3, 4, or 5 lobes. And then, as I said, this cytoplasmic granules, they do not strongly stain, and these granules, they are filled with digestive enzymes. As I said, that these are the most abundant. About 70% of the white blood cells are neutrophils, and they are the first cells to approach a site of a problem. When there is infection, then they are the first cell, the fastest response of all white blood cells. When there's bacteria, when there's a problem, they will collect at the site of infection immediately. And what they do is that they remove the foreign material, but by phagocytosis, not necessarily bacteria, but also the dead cells that are formed there because of the infection or because of the injury. So they remove the dead cells as well, phagocytosis. And once the substance is engulfed inside the cell, then these granules, which have digestive enzymes, they are going to digest the material. They have strong oxidants. They have like antibiotic effects called defensins. So they are going to kill the bacteria. Multiple mechanisms to kill the bacteria or digest the debris. So they are the fastest to reach, and they are the most prominent or most abundant type of white blood cells, the neutrophils. Then we have the eosinophils. They have a nucleus which has 2 lobes and connected by a band, only 2 lobes. And as the name indicates, eosinophils, the granules, they like eosin, which is a red dye, and so they appear as red, dark red, large granules in color, and they contain enzymes that attack parasites, and they end allergic reaction. One of the mediators of allergic reactions is histamine, and so these granules, they have an enzyme which is called histaminase, which will stop the allergic reaction, and at the same time they have enzymes that kill parasites. So whenever we have eosinophilia, which will appear in the differential blood count, this will give an indication that there is some sort of allergic reaction or there is a parasitic infection. Then we have the third type of granulocytes are basophils, and these they have very large granules that attract basic dyes. They appear purple in color, and they overshadow the nucleus, so the nucleus is not clear. Although they have a nucleus, but you cannot see the nucleus easily because it is obscured by these cytoplasmic granules. And these cytoplasmic granules, they are basic loving, then they contain the machinery for allergic reaction. So they contain histamine and heparin, the histamine which is needed for allergic reaction. So again, basophilia indicates allergic reaction when they are increased in number. The agranulocytes are 2 types. If we go back here, we will find that we have either lymphocytes or monocytes. So I will start with the lymphocytes. Lymphocytes are actually the second most abundant type of white blood cells. We have like about 20-25% of the white blood cells are lymphocytes, and they are agranulocytes. They don't have granules in the cytoplasm as seen by light microscopy. And as you can see that in the lymphocyte, the nucleus is rounded and occupies almost the entire cell. You can see that there is a very thin rim of cytoplasm here. Most of the cell is a nucleus. They have an important role in immunity. We have 2 types of lymphocytes. I'm going to return back to lymphocytes when we deal with the immune system. But I will catch up with what we started previously when we were dealing with the thymus. We said that the thymus is important for the maturation of T lymphocytes. So lymphocytes, they have their precursor cells present in the bone marrow. Like any other cell in the blood, have the precursor in the bone marrow. So the lineage, the precursor cells for the lymphocytes are present in the bone marrow. But these are immature cells, and they will produce 2 types of lymphocytes to start with. T lymphocytes and B lymphocytes. B lymphocytes are produced in the bone marrow, and they remain in the bone marrow to become mature and then return back to the blood. The T lymphocytes, they are produced in the bone marrow, but they are circulated by the blood to the thymus. And in the thymus, they will become mature and then return back to the blood. That is the difference between them. It is the place of maturation. Both of them are produced in the bone marrow, but the place of maturation is different, and the function will become therefore different. So B lymphocytes, which are produced and mature in the bone marrow, whenever they are triggered by an antigen, for example, let's say a bacteria, then they will change into what we call a plasma cell, and the plasma cell will produce antibodies to attack the bacteria and produce antigen antibody complexes that are going to be attacked by neutrophils and phagocytized by neutrophils. Okay, so they destroy, by this way they destroy the bacteria. The T lymphocytes, there are different types of T lymphocytes. I'm not going to go into details, but one of them is called the natural killer cells, and these, the T lymphocytes, they inject cytotoxic substances into the infected cell and kill that cell. And there are, of course, there are other types of T lymphocytes, call them helper cells, there are memory cells, and there are suppressor T lymphocytes. If you have studied that before, then that's good. If you haven't studied it, then we are going to talk about the different types of T lymphocytes when we deal with the immune system. Now we care more about the shape of the T lymphocyte, and the site of origin. B lymphocytes and T lymphocytes cannot be differentiated by light microscopy. According to the morphological characteristics, they cannot be differentiated. Both of them, they have a rounded nucleus that occupies most of the cytoplasm. And then we have the monocytes. These are the largest of the white blood cells. They have the nucleus here, as you can see. They don't have granules on the cytoplasm. The shape of the nucleus is obvious. It's like kidney shaped or horseshoe shaped. It's not circular. It's either kidney or horseshoe shaped. Most of them, they don't remain circulating in the blood. They will leave the blood and go to the site of infection, or even leave the blood and reside somewhere in the body, and will form what we call the macrophages, the large cells that are present in certain places in the body for defense. For example, we have the alveolar macrophages. If you have studied the lecture on respiratory system, you will notice that there are macrophages in the alveoli, and these remove the dust particles, alveolar or carbon particles, and they will remain in the tissue. That's why the lung of a smoker or a dweller of an industrial area, the lung is mottled. When you dissect the fresh body, you will find that it is mottled with black spots, because these are the ingested carbon particles of these alveolar macrophages. Or in the liver, called Kupffer cells, and they are going to destroy not only the bacteria and toxins, but also remove the old red blood cells. Or we have them in the skin, in the epidermis. What do we call them in the skin? Langerhans cells. Okay. Okay, so they are Langerhans cells. Remember that there are 5 types of cells present in the skin: melanocytes, Merkel cells, Langerhans cells. So the largest of the white blood cells in the circulating blood, they don't remain in the blood for a long time. They migrate, they gather at sites of infection, they function as phagocytosis, but they take longer time than the neutrophils. So the first squad that's going to arrive to the site of infection is the neutrophils, and then it will be followed by the monocytes. You can watch this optional video, very, very nice video, showing you how white blood cell navigates itself so that to leave a blood vessel and reach the site of an infection, an actual. So whenever there is infection, then we would expect that there is increase in the number of white blood cells, and this is what's called leukocytosis. If the number is more than 11,000 per cubic millimeter, then there is leukocytosis. But sometimes it's not only infection, sometimes it's because of excessive exercise. Any stress like anesthesia, surgery might result in formation of more white blood cells. You can see this is a normal blood smear. In this one here, there is most of the white blood cells, as you can see them here. You would expect that most of the white blood cells, they should be neutrophils, but most of the white blood cells that are shown here are the bilobed cells with the red granules. So these are eosinophils. So this means eosinophilia, and this indicates either a parasitic infection or an allergic reaction. Leukopenia is the reduction of amount of red blood cells in the blood, less than 5,000 cells per cubic millimeter, and this takes place whenever there is chemotherapy, which usually reduces mitosis. And as you know, that there is a continuous process of mitosis taking place in the bone marrow, so there will be a reduction in the amount of production of white blood cells or radiotherapy. And as I said, that the differential count, as you can read here, differential count is probably as important as the number of the total white blood cells, because it will give you an indication of the disease that caused increased number of white blood cells. The last element here are the platelets, or we call them thrombocytes, because they induce thrombosis. So they are thrombocytes. They are disc-shaped, and they are very small, smaller than red blood cells even. They don't have a nucleus because they are fragment of cells. These are the cells that are present in the bone marrow. So this is a bone marrow section. You can see it here. All these cells, they are precursor cells for either red blood cells or white blood cells. And you can see that there are, for example, here, these are red blood cells, mature red blood cells. They are circulating, and these are the precursors. But if you look here, you will find that there is a very big cell. Compare the size of this cell with the other cell. Here's another one. So these are what we call megakaryocytes, and their fragments of the cytoplasm will go into the blood and will form the platelets. Okay, what are these spaces here between the cells? Are these spaces or what? What is there in the bone marrow? What types of bone marrow you know? Red bone marrow and yellow. So why is it yellow? Because of fat. So these are fat cells. They are so adjacent because red bone marrow is adjacent to the yellow bone marrow. And they promote clotting of blood. So you can see here the fibrin threads, and then the platelets will come and clog these spaces. Of course, this requires stimulation of certain clotting factors. Bone marrow examination, because all these cells are produced in the bone marrow, then whenever we have blood disease, then it's better to examine not only the circulating blood, but we'll go and have either a bone marrow aspirate, where they aspirate with a narrow needle, the bone marrow, or they will have a piece of bone marrow taken out, and this is called bone marrow biopsy. And so depending on that, and usually we have mentioned that before, bone marrow is either taken from the iliac crest or from the sternum, because here we have red bone marrow to start with. We don't want to take bone marrow and then it's all fat cells. No, we need a red bone marrow. And then we need a bone that is easily accessible just underneath the skin. So that's why these are places that are used. And then this is here to show you the common site of doing the phlebotomy or venipuncture. In front of the elbow joint, we have a fossa, which is called the cubital fossa, and there's a vein, which is called the median cubital vein, that communicates between the cephalic and the basilic veins. Both these veins, they are superficial veins. They are just underneath the skin. They are not accompanied by arteries. But definitely, you don't need to push your needle deep, because in this case, if you go deep and you puncture the vein, then you might reach the artery, which is underneath the vein, underneath the fascia.